που αφορά την χρήση της αντλίας Α8 TouchCare Automated Insulin Delivery System στη διαχείριση του ατόμου με σαχαρόδι διαβήτη. Είναι ένα πολύ ενδιαφέρον θέμα. Ξέρετε ότι στην Ελλάδα έχουμε 35.000 άτομα που έχουν σαχαρόδι διαβήτη τύπου 1. Δυστυχώς οι αντλίες στην Ελλάδα δεν πολύ χρησιμοποιούνται. Όλα βέβαια τα άτομα με διαβήτη τύπου 1 έχουν συστήματα συνεχούς καταγραφής γλυκόζης, αλλά μόνο ένα 15% χρησιμοποιεί αντλίες ινσουλίνης. Έτσι έχουμε ένα νέο σύστημα χορήγησης ινσουλίνης με αντλία και είναι ιδιαίτερη χαρά και τιμή να έχουμε μαζί μας σήμερα την κυρία Μπάρμπορα Dolezalova. I pronounce your name correctly, I think. Είναι ενδοκρινολόγος, έχει μεγάλη εμπειρία στη διαχείριση του διαβήτη, στη χρήση αντλιών ινσουλίνης και ιδιαίτερα με την αντλία της Medrum, για την οποία θα μας πει την εμπειρία της. Και θα ακολουθήσει η συζήτηση. So, please, Barbara, go to the podium.
Dear Professor, ladies and gentlemen, it's my great pleasure and honor to stand here in front of you and present a system of automated insulin delivery, which is new to Greece, but which will surely be a new possibility for your type 1 diabetes patients to get not only better results in their diabetes care, but also a great change in their lives. I would very much like to thank for the invitation to Greece. And I would also like to say that I'm from Czech Republic, and yesterday I traveled for 10 hours and I traveled across 1,500 kilometers to make a mission here, to commit something, because I don't only want to introduce a new system, but I would love if you think about your own work and about your own patients. And if you think about people who may use this system and have the benefit of it, that would truly be what I came here for. I divided my lecture into 3 parts. The one will focus on automated insulin delivery in general, because it's only when you acknowledge that this new approach to the insulin treatment is beneficial, that you start thinking about pumps. Because nowadays, it's not about the pump the patient has attached to him or herself. It's about the system in which it delivers insulin, because that's the changing point. And if you think that you might have patients who would profit from improvement of their glycemic control and they would need the automated insulin delivery, then you start about choosing the correct system for them. And that's where TouchCare is really something new and something that makes the pump therapy, let's say, attractive for patients who never considered a pump before. And then I would also like to spend a few words with daily life with this system. So first, I'm sorry, I have to stand here, okay. So first, I would like to say a few words about the automated insulin delivery in routine care. And for this, I chose 2 guides who are actually my patients. And I would like to introduce you to both of them, because they live 2 different lives, but have only one type 1. The first guide is Miss Anim. I call her Miss Anim. She was born in 2006, so by now she's 18 years old, and she was diagnosed with type 1 when she was at the age of 5 years. So far, she has no complications, and I would say that her diabetes was completely okay as long as her mother was in charge of everything. But now she's 18, and she moved away from home, and her situation has changed very much. Before she had a change. She injected fast aspart insulin with as many as 14 units per each meal. And she also used insulin glargine, 40 units per day. She has normal weight, and the result of this treatment was HbA1c of 10%, which, as you acknowledge, is terrible. And also the data from her Libre system, which she was using before, correspond with this number. So there's a huge, space for improvement. Another story is Mr. Perfect. Mr. Perfect is rather an older man. He was born in 1948, and he also has a long-standing type 1 diabetes with diabetic neuropathy, and he has also some other neurologic conditions, so his movement is not really fluent. He's living alone, and his aim is to remain independent as long as possible without any need of any nursing facility. He has much lower doses of insulin. He also has a normal BMI, and his diabetes control is one of the best. He's one of the best patients I have. And here is his sensor data. And if you see it, then you know that finding him the nickname Mr. Perfect was not a Nobel Prize task. What I would like to say about these two characters is that with Miss Anim, it's me as a doctor who calls for change. I know, or I believe, that this patient, as many of other type 1 patients, are doing their best. However, their best leads to HbA1c of 10%, which means not a risk of complication. It means a security of complications later in life. While with the other patient, I'm happy, and I'm actually not suggesting any change, but he is. Because he says, well, I don't have these very nice figures, just that it would come out of the blue. I spent whole my life, whole my time solving this diabetes equation again and again. And maybe one day I will not be that much fit. And he knows that diabetes is an intriguing, challenging, and complex condition, and he has no one to help him with it. So he says, well, maybe in 4 years, what will I do? I will have to rely on people who know nothing about diabetes. So I need a safe solution which is independent of my own time and of my own mental capabilities. Let's see the official statement. What does ADA recommend for such patients? It says in Chapter 7 that the automated insulin delivery should be offered to all people who are capable of using it. And it also says that the choice of the device should be basically let on the patient. But, as I said, acknowledging that AID is beneficial for our type 1 patients is crucial, and then the patients can choose. In Czech Republic, in country where I work and live, every diabetes specialist can start a person with type 1 diabetes on a pump, and I was led to believe that it's the very same in Greece. The difference between the countries is not the population, because we have 10 million people as well as Greece, but we have a greater prevalence of type 1 diabetes. We think that we have about 60,000 patients, and we don't have that many diabetes centers so that all patients could go to centers. But every type 1 patient should have the same access to the best care, so we believe that it's important that even normal diabetes specialists in a regional city or even smaller city have access, have knowledge, and can convey this therapy to the patients. And I did a lot of work in it, I believe, because I myself have 85 type 1 diabetes patients. I had much lesser number, but many patients found me because I'm using a lot of technology. Almost all of them use CGMs. And before we had the automated insulin delivery, I usually had more or less 7 people on pumps. Those were those selected patients, those who we said deserved pump therapy. Today, I have 43, and they are all using the automated insulin delivery. I would never let a patient use a pump if this does not have this automatic feature, because this is the changing moment. And here in this graph, made by myself. I just want to show that the landscape of the pump therapy in last 4 years changed completely. Some of the pump species we had got extinct completely because it had no cooperation with any sensor, while new insulin pumps appeared, and we started employing them in our patients. So I mostly use the Control IQ system, which is the connection between tandem pump and Dexcom sensor, and it's probably not that much used here in Greece, but nevertheless I also use the Medtronic pumps, which are the prevalent pumps here, and I also use this new A8 system, and that's what I want to talk how it came to my practice and how it came to my patients. So I have more than or almost half of my patients on AID. And what's my own goal is that I believe that 3/4 could do it, and it's my job to put them on a system they can manage, and that can manage their diabetes. Of course, we are in Europe, and we will always call for a big data, but unfortunately, there is not really a big study that would support using the TouchCare system in a real practice, but it's been used for some time in the NHS in Great Britain, and they do have a real-world study, an observation study, where they studied more than 500 patients on all different types of automated insulin delivery, and the Metron TouchCare system was also included among these patients. This study was aimed at people with very bad glycemic control. The entrance condition, the inclusion criterion was that their HbA1c was above 8.5%. So really these were people who desperately needed help with their diabetes. And as a result, these people improved from time in range of 34% to 61%. The main findings in this British study were that the HbA1c changed profoundly, minus 1.7%. The percentage of patients who had good glycemic control given by the HbA1c below 7.5% went up from 0, because it was the inclusion criterion, to almost 40% of people with good diabetes. And this applies to all metrics of glycemic control we can think of. Basically, they say that the main finding is that the people have improved quality of life, and the results were similar across all systems used, be it Medtronic or Control IQ or the Metron system. So with this, I would like to say a few words about the system itself, that I consider it attractive, efficient, and a safe choice for our patients, because of course we care about safety. When we come to attractivity, of course we should ask the patients what they think. And this young lady thinks that she needs a discrete solution, of course, which doesn't disturb her body and also doesn't disturb her activities, whatever she might have. While the man, the Mr. Perfect, says that he seeks a smart ally that manages glycemia as well as he himself, and he has problems with moving, so he doesn't want any tubing. This is about attractivity. Now let's see what we can offer with Metron system. We can offer a small sensor connected with a small pump that holds up to 200 units of insulin, and these components are connected together with an application which is either in the mobile phone, be it Android or iPhone, it doesn't matter, or if the person doesn't use mobile phone, it can use a small manager called PDM, Personal Diabetes Manager, which is about half size of a smartphone. And it also has the mirroring in Apple Watch if the person uses it. As I said, the sensor is small, it's discrete, and it's convenient. It may be calibrated, but it's not compulsory, and it's easy to use. It can last up to 14 days. When it goes about the pump, it's really small, it's light, it's discrete, and it's controlled by the application that the patient has in the phone. but the application has also its mirror side within the pump in the white part, which is called the base. And the base is reused with each gray part, which is called the patch, and the patch has the reservoir for insulin, and it also contains a small battery. So every time you change the system, every 3 days, it has a fresh battery, so there's no need to change the batteries. It has also one more option for people who use more than, let's say, 90 units of insulin per day. This also has another option with the 300 unit, and that's the only word, 300 unit patch pump. So this is what we can offer. And now about its efficiency. The application offers automated insulin delivery, so it protects the patient both from hypo and from hyperglycemia. And now, for me as a diabetes specialist, it's a bit painful to say that, but even the automated insulin delivery systems across the world showed that carb counting is a weak point of the system. So what this system offers, and it's really unique, is so-called auto meal handling. When the person doesn't have to input carbs anymore, it just announces the system that he or she is going to eat. And the system applies some safe bolus, but it applies it, let's say, timely, and then it waits a little bit about where the glucose goes, and it applies more bolus. So it's very safe. And if the person wants to use the bolus calculator, it can use the bolus calculator and input carbs. But with auto meal handling, there's no more need of carb counting. Now we're doctors, so of course we do care for safety of the system. And I always say to my patients that they don't need to be afraid that this system will be aggressive, because avoidance of hypoglycemia is the top priority in all automated delivery systems. This system checks the level of blood glucose every 2 minutes. And basically that's the miracle, because it only delivers insulin for next 2 minutes, because then it's going to recheck. I was once in Vienna and heard a lecture given by Professor Battalino, the author of the Time in Range Consensus. And he said, the miracle of automated insulin delivery is that it never has a headache and it never feels offended that you ask it the same question every 2 minutes. What's the glucose and what insulin should I dose? It doesn't feel underestimated. It doesn't feel at all. It just calculates insulin and gives for next 2 minutes, and then it redoes the same task, which is completely out of human possibilities. And that's why these systems are so good in checking and correcting glucose. It also has one special feature which, to my knowledge, the other system don't have, and that's if the patient has a long hypoglycemia, if it happens and glucose goes around 3.5 and it takes more than 2 hours, it starts delivering some very tiny bits of insulin to avoid DKA in future. I already spoke about bolusing in auto meal handling. You announce, for example, that you are going to take a lunch. The system consults the previous data from previous days. It calculates a typical bolus and it delivers some percentage of what it calculated. It never delivers everything because it rechecks and delivers the rest according to where glucose really goes. So it works for different meals. There's no need to eat all the time the same meal or the same carb grams. And then another sort of safety feature is that the data, as long as the phone is online, goes instantly to EasyView portal, which is the doctor's side of the whole system, and we can see our patients in real time. Now let's move to the daily life, how the patients do it with TouchCare. And of course, both of our guides chose TouchCare for the management of their diabetes. So we first changed their sensor because it has to be connected with the A8 nanosensor, as I introduced it before. The education is usually done by a commercial educator. So with this system, you have another person in your team. You even don't have to pay him or her because it's their business. They go and they introduce every technical feature of the system to the patient. Then we have the D-Day, when we all meet, me, the educator, the nurse, the patient, and sometimes even some near persons to the patients can come with. And we program the basal rate. We also program the bolus calculator. I would like only to briefly say that in Medtronic system, which many of you probably know, you don't say what the sensitivity is, because the system calculates itself. But with this system, you do input insulin sensitivity in the bolus calculator. And with this single parameter, you can change the system. You can have influence on the system much more than with the Medtronic system, which otherwise is very good. And of course, this also has individualized glucose targets for the patients. And then I, as a doctor, give them some additional education about traveling with the system, DKA signs, and what to do if hyperglycemia persists, to check everything, change the system, and it's the same as with other pumps. Now, how they do live with TouchCare, this is what Miss Anim had, and this is what she has now. The automated insulin delivery breaks the barrier in the person. It adapts diabetes to the life of the person with any further need to adapt herself to diabetes. But to be honest, well, now let's see Mr. Perfect, because it was maybe even a harder task with Mr. Perfect, who had really high expectations from the system, that he remained as good as he was with no additional hypoglycemia. Now, I would like to say that Miss Anim, as a young person, she has much closer relationship with all her gadgets, with all her things that she carries with her. So she is much better in keeping the TouchCare system working than she was in correcting her blood glucose. And that's true for many, many people. I always say that I changed their task. No more counting of blood glucose and carbs. Their task is to keep the system alive, to have a good sensor, calibrated, always pump, always some additional parts with them in the bag, and a power bank for the mobile phone, of course. And what Mr. Perfect is doing, Mr. Perfect is doing nothing about his diabetes. He's completely enthusiastic that he may let go, because this friend of him really takes care of glucose, and he can live his own life. Now, a closing remark on why it outperforms MDI, and I have already said it many times. Miss Anim used 60 units with terrible results. And of course, the worst advice I could have given her would have been to inject more insulin. And we have been doing that for a lot of years. Now she uses 33 units, and all her beautiful results are made with 33 units, which are divided by the system to half and half, so almost a perfect situation. And the red rods in the graph only demonstrate how much insulin she used before and how much different the concept of insulin delivery is with the AID, that sometimes it leaves your insulin level low, so it prevents hyperinsulinism. And I believe that in many years, when we can assess diabetes complications, this will be one of the key features that this has for the patients. Just to show you, I don't have only these patients, of course. I have many patients, I have 14 patients on this type of AID. They all improved. And although I didn't put perfect patients, no way perfect patients, on AID TouchCare system, now each of them spends on average 5 hours more in range. And we know that, for example, some insulin like Fiasp, if they are compared by the CGM, they say, well, okay, just switch of insulin brings you 40 minutes more, and it's clinically significant. Now you have 5 hours more in range, just thanks to switching to auto mode of TouchCare. And they all have increased time in range. This system really has low risk of hypo. 2% of hypo is nothing. They, of course, have decreased HbA1c, and it has a high proportion of responders. And this is my last graph, where I show that all systems that I use, TouchCare as well as Medtronic, as Control IQ, they all help people, even those who are not helped by the sensor itself. It further reduces HbA1c, and also it improves their lives. To say the last things, I believe that AID has the best performance in glucose management and should be at least offered to all type 1 patients. Avoidance of hypoglycemia always is the highest priority. So lower HbA1c and higher time in range is a little bit secondary because it cares for the safety of the patients. Now, the patch pump TouchCare system makes the pump therapy attractive for many patients who would never consider another system. This is the way to this, and the improvement, at least in my practice, is comparable completely to other well-known systems. And the miracle is that it cares for glycemia every 2 minutes. And with this, I would like to thank you.
Thank you very much for this excellent presentation. So we have time for some questions. Please have a seat. And σίγουρα το ξέρουμε ότι πολλά άτομα με διαβήτη τύπου 1 έχουν πρόβλημα με τις αντλίες που έχουν καλώδιο. Πιστεύουμε ότι τα tubeless συστήματα ότι θα αυξήσουν την δυνατότητα χρήσης των αντλιών ινσουλίνης σε περισσότερα άτομα με διαβήτη τύπου 1. Κάποια ερώτηση, κάποιο σχόλιο? Ναι, κύριος Μαρκάκης. Στο μέσον, μικρόφωνο.
Thank you for the interesting introduction to this new system. I found highly interesting this feature about just announcing the meal instead of inserting the exact carbohydrate amount. And in my knowledge, the only pump that has introduced this system, this feature so far is the iLet pump in the United States. And of course, this would be extremely very convenient for the patients. My question is, first, if there is any option in this feature to further define the meal as small, medium, large, or something like this. And the second part of my question is if you have any data so far about how this feature works in terms of glycemic excursions, and if there is an increased risk of hypoglycemia. Thank you.
Thank you very much for this question. I would maybe start with the other part, because up to my knowledge, there is unfortunately no big data in terms of some statistics study. That's why in Czech Republic, where we have almost 300 patients, we start a registry study where we will observe this also with respect to this feature. But technically, if you put your patient on this meal announcement, he or she announces 4 types of meals: breakfast, lunch, snack, and dinner, where snack is considered this small meal. So the system basically knows what kind of meal it is, and it's also based on calculating from the other days, so that it's as accurate as it could be. And then there is this Safety Plus, which only delivers a part of the calculated bolus. Well, but at the same time, the patient can also use a normal bolus calculator as he or she did before that. So it's both possible. Thank you.
Thank you very much. Of course, you realize that if I announce, let's say that I have a dinner, okay, the pump will assume that I'm going to have my usual dinner, but many people do not have the same amount, the same time intervals of the day. So I don't know, perhaps there is
maybe let's
something
switch to numbers. If you usually have a dinner and you need, let's say, 7 units of insulin, then this auto meal handling will deliver you 4 at instant, and then 3 will appear, let's say, 40 minutes later, depending on where the glucose goes. So if you then count it all together, it will be more or less the same, but the dosing pattern is different, and it's much safer.
Άλλη ερώτηση? Do we have any experience in children with TouchCare?
Yes, I would like to talk about Czech Republic, where I know the data that we also use it in children, but they must use as much as 12 units of insulin. If they are too small, then either the insulin solution has to be diluted, but it cannot go with less than 12 units because the occlusion would occur. But if the insulin need exceeds 12 units, this can be used. Or in Czech Republic, some people use it with a different sensor with Dexcom in another loop. But yes, it is well the most attractive for the parents of diabetes, of children with diabetes, because it's so easy, and compared to the other pumps, it's much more convenient for the kids.
And we are at the beginning of using this system, but you have experience. So did you face any particular problems with TouchCare until now?
Until now, I think that the most intriguing part of the year is summer, when the people bath and swim. It's not that the pump would fall away. On the contrary, some people have itching under the patch because it's like this big. So I think that skincare then is very important in all the users of this. And it's true that it's waterproof, but if you go diving or if you go to a warm bath or this jacuzzi bath, it can jeopardize the pump, but under normal circumstances this is okay.
Okay, thank you. Σπύρο, πήγαινε στη μέση, μπροστά.
Thank you very much. It was a very interesting talk. Just to be clear, all the software is on the phone. When you get away from the phone or you switch it off or in flight mode, does it use the automatic mode or switches to manual?
Thank you. Thank you very much. This is also important because no one wants to be the slave of his or her own mobile phone. So you do all programming in the mobile phone because the pump itself has no communication interface, but once you program something in the mobile phone, you put it next to the pump or, well, somewhere in the reasonable distance, and the system makes a copy in the base of the pump. So even if you change the patch, you have the same base. So the system with all its parameters remains in the pump. It's different if you lose the connection to the sensor. Then it has 3 hours with a sort of automatic basal. So it compares the last, I don't know, 3 to 7 days, and it delivers automatic basal. After it does have no connection to sensor for more than 3 hours, it goes to pre-programmed basal, and I think it's very comparable to this same feature of Medtronic.
Okay, αν δεν υπάρχουν άλλες ερωτήσεις, thank you very much for being here with us and sharing your experience. Και εσάς που μας παρακολουθήσατε.